And I'd also just very briefly like to congratulate the Student Society for being global in their vision and their reach. I think it's really impressive that you're hosting this, so thank you. So you've asked us to speak on the concept of quality indicators and what quality might be in the context of global palliative care. And I'd just like to start with a caveat, first of all, because we're going to talk about categories of high, middle and low income countries. So the first thing I want to say is within these groupings of high, middle and low income countries, there is enormous diversity, and I'm very kind of cautious about lumping countries, regions into these kind of broad categories, because if we just take the example of Africa, which is where most of my work is, we're looking at over 1 billion people. We're looking at over 20 million people living with HIV, over 1 million annual deaths. We're looking at 10 million HIV orphans. We're looking at the issues of child-headed households and high levels of child mortality, which we don't see in high-income countries, so palliative care looks different. We're looking at nearly 500,000 deaths. We're looking at 70% of cancers globally being in developing countries by 2020. We're looking at the health systems, which vary so much, but has some key themes like late presentation and fewer curative options. We're looking at 51 different low-income countries. So just to talk about Africa and low-income countries does give me a little bit of kind of anxiety. And then within countries, we're also looking at enormous amounts of diversity. So if we take the example of Nigeria, Wikipedia tells me that there are over 300 tribes and 3 major ethnic groups. And then if I look at Kenya, there are 10 different identified ethnic groups which make up less than 2% of the population. So this is my caveat before we start talking about kind of regions and low and middle income countries. There's an enormous amount of diversity within these categorizations. So to start thinking about what we might mean by quality in health services, and particularly in the context of palliative care, I'm just going to take this from Fliss Merter. Here is one of our senior academics and a clinician here in the Institute. When she was writing her thesis on renal palliative care, she identified these concepts of quality within the existing literature. Things like effectiveness, capacity, acceptability, patient-centeredness, very important to palliative care, accessibility, efficiency, equity, legitimacy and relevance to need. And I'm going to run through these now in the light of what we have discovered in the past 10, 15 years in palliative care research and how it might relate, the evidence might relate to these broad categories. So first of all, if we take together effectiveness and patient-centeredness, it's really clear, if you look in PubMed, you look at the existing literature in palliative care, that there are many systematic reviews that demonstrate that palliative care is effective when compared to standard care. That evidence is largely in cancer populations, it's largely for palliative care at the end of life, and it is in the main generated in high-income countries. However, low and middle-income countries are catching up, and since our initial review of the evidence in Africa in 2005, there has been an exponential growth in the evidence. However, I want to argue and propose in these following slides that although the balance of effectiveness evidence might be from high-income countries, I would say that perhaps the balance of evidence for patient-centeredness might be coming from low and middle-income countries. And why is that? I think one of the main reasons we've been able to focus on patient-centeredness is the evolution, particularly of the African version of the palliative outcome scale, which came from our original systematic review showing real clinical innovation and excellence on the ground, but a great need for outcome measurement. We consulted with professionals to understand what an outcome tool to promote patient-centered care might look like, developed an African version of the POS, piloted it in 8 countries in Africa, and then eventually validated it with around 1,000 patients and carers. So that's really led the achievements in patient-centered palliative care delivery, I think. And in terms of ownership and leadership, an enormous amount of leadership has come from African advocacy agencies such as the African Palliative Care Association and the Hospice Palliative Care Association of South Africa, who deliver this free guidance on how to use the palliative outcome scale here and guidance on how to use it to measure care and to deliver more patient-centered care and to measure the effectiveness of that. Really importantly, a lesson for us that measurement of patient-centered care is becoming a standard. in sub-Saharan Africa. If we look at the Hospice Palliative Care Association standards in South Africa, if you want to be accredited as a 5-star hospice in South Africa, you have to be using the POS or an equivalent patient-centred outcome measure, which I think is an enormously insightful standard to ask of care providers. And then within APCA, there's also similar requirements that here the ruler is the key, that we measure patient outcomes as a standard of care, and Julia will talk more about that. And in terms of taking patient-centred measurement out into new populations, the paediatric African POS is the first in the world. It's nearly validated now across a number of countries, which of course has been a complex approach to looking at children's needs to take into account things like stages of development, play and feeding, and all those challenges around proxy scores, so who can score a pre-verbal child, which has been underpinned by some systematic reviewing, and we, with Julia, have published some quite innovative methods on how to develop and implement a children's version of the POS. Because palliative care has emerged mainly from East and Southern Africa, there has been some growth recently to get palliative care outcome measurement in Arab versions, so particularly with Dr. Nala Gaffer in North Sudan and David Fearon in Mauritania develop Arab versions now. And also we're working with Harvard to get a Vietnamese POS, which has been really interesting because of the cultural diversity between North and South Vietnam, and also taking account of the specific needs of people who've contracted HIV through injecting drug use. So again, there are very cultural dimensions to our measurement. Really interestingly, right now we're working in South Africa to roll out patient-centred outcome measurement to every single government clinic, HIV clinic across the country, and we're developing that tool now. Incredibly exciting work. Moving on to our next definition, capacity and equity. Well, the WHO Global Atlas of Palliative Care recently came out and showed us that only 10% of the 20 million people who require palliative care annually actually receive it. And 80% of the need for palliative care is in low and middle income countries. The World Palliative Care Alliance World Classification with Lancaster University revealed at the end of last year that only 58% of countries have at least one palliative care service. That's just the criteria here. So just over half have got at least one. The poorest ratio for any country that indeed does have a palliative care service is Pakistan, where they identified that there is one service for a 90 million population. So coverage, equity, capacity are clearly issues. So models of care are a really, really important consideration here. Because if we look at, for example, providing palliative care for the 22 million people in sub-Saharan Africa who need palliative care from diagnosis to death, how do you do that for 22 million people? We ran the largest evaluation of palliative care for the US government, and we discovered here in 1,300 HIV outpatients in East Africa, on the palliative outcome scale, looking at their pain in the last 3 days, if we take this mustard and orangey red colour at the end, we can see that around a quarter to a third of patients have significant pain which needs to be managed. How do you do that if you've got quarter to a third of 20 million people requiring pain relief? So integrated models are absolutely essential. If we take it up to this quality of life measure that we used, looking at pain in the last 30 days, we're looking at around half of people have had pain in the last 30 days, which is moderate, severe or very severe. And really important when we think about what this might mean for somebody who maybe is a subsistence farmer and has to work to generate food and income for the family. If we ask them about how much pain in the past 30 days has interfered with their normal work, we can see it's been a massive issue. So if you're going to take on a concept of total need as a measure of quality in palliative care, total needs are enormous if you've got interference with ability to work, because that affects the whole family. Acceptability and accessibility, which is clearly linked to capacity. And again, the idea of different models of palliative care is key, because we cannot import palliative care service models from other parts of the world. We've published some data looking at the concept which we espouse here in the West, in the rich West, talking about advanced care planning. And actually people had great concerns about whether advanced care planning worked, particularly in the Eastern Cape of South Africa, because advanced care planning, first of all, implies that you have a choice. And actually, if resources are limited, you don't have a choice. There are gender issues, which means that actually often women in the family don't get to make choices, it's the men. And also, we come from a very individualistic society, and in more communal societies, it's the family and larger communal groups make decisions, not just the individual. So things like advanced care planning may not be appropriate. And of course, a key issue today is going to be about drug availability as a quality marker. We reviewed 120 facilities in East Africa and checked the pharmacies for drug availability. And while we often talk about opioids and step 3 analgesics, we found that there was a really high level of stockouts and problems with accessibility of even step 1 analgesics for things like paracetamol. And I've been working in a government clinic in the Cape Flats where you can only prescribe paracetamol for 3 days. So it's really difficult to control pain. In Kenya, we found opioids in only 1 out of 60 HIV facilities in their pharmacy, and that was an injectable format only. We've also identified that there's really restrictive policy and legislation architecture in many parts of sub-Saharan Africa. And I've just started visiting cancer services in India, and there's some very interesting data here from India. We can see the Indian annual morphine equivalent per capita is this for India, and that's what it is globally. So there's a huge disparity between opioid consumption and availability between different regions of the world. In terms of acceptable models of palliative care, if we're really providing it from diagnosis to death, how do we manage that and provide acceptable formats of palliative care for clinicians and patients when people have pain symptoms and distress all the way from diagnosis and are likely to live for decades alongside antiretroviral therapy? So we need to think very carefully about what a quality service might look for that kind of coverage. And also we talk about place of death a lot, and we recently completed a large European study with African partners. We found in Namibia home death was preferred by around 1/3 of the population and around 1/2 in Kenya, compared to our data in Europe that found it was nearly 70%. Now, why is that? Is it because people don't want to die at home, or because there aren't good services to enable people to die at home? I don't think we really understand that yet. Efficiency and relevance to need. We know from Eki Kikuli's data from Uganda way back in the late 90s that in line with the WHO definition, we know that needs are physical, social, psychological and spiritual. We share that global definition. But also some work we've done on a project here in South Africa and Uganda funded by the lottery, some work published by Lucy Selman showing that actually when we look at quality of life in advanced disease patients, spiritual well-being was the most important dimension of quality of life. And communication needs. These again aren't universals. Although people in Africa that we have interviewed identified that they want information, how that needs to be provided is quite complicated and varies culturally. We know that in our street surveys that I just referenced, in Kenya just over 1/2 and in Namibia 60% of people do want to know that they have a life-limiting condition. But then when we look at what happens in practice, we did some work in Cuba on the wards of the main referral hospital in Havana that found that less than 1/2 of cancer patients who had a cancer admission actually knew that they had cancer. And even though they had advanced disease and poor prognosis, less than 10% were actually aware that they were dying. So there is patient preference and there are medical cultures that we need to address in terms of understanding what quality communication is. And we can't really, I think, decide what relevant communication needs are without conducting this kind of research. One of our students has published some data from Bangladesh from our master's course, which found that patients weren't being told about their diagnosis and were being encouraged to access very expensive private treatment, being over-treated in the absence of palliative care services which could present them with a different option. And I've recently been in India where, in terms of disclosure, there was a much greater focus on information and communication happening with the family, who then are responsible for communicating to the patient. So there are very, very different preferred models, I think, when we're talking about what quality communication information are. And when we talk about efficiency, there's very little data currently from low and middle income countries, although we have recently published some data from a South African very novel hospital service which found that a palliative care service could reduce admissions, reduce length of stay and increase the home death rate. I think this is probably the most complicated concept of quality for us to address is legitimacy, which Don Abedian calls is what is optimal care for a society. And I think globally this is a very, very difficult question for us to address, and it needs to be evidence-led and needs to be locally determined. particularly when we talk about things like total care needs. We talk about meeting people's social and spiritual needs. Actually, what that means locally varies enormously, and we have to have evidence to understand what a total care need is. We have to take into account cultural preferences, and we've been working with traditional healers in the Eastern Cape, trying to understand what a good death is in terms of working with ancestors and making sure that in a year's time, when the ancestors return post-death, that things have been put into place that the family feel peace. So there are an enormous amount of cultural traditions which need to be taken into account when determining quality. And in terms of what's a legitimate service, also can be very much determined by the community. And there are great models which some of you might know, for example, the Kerala model in India, which is community-led, and the model of Hospice Africa Uganda, which is about finding a model of hospice which is relevant to Africa. So I think while we share common strategic approaches, which is about education and effectiveness and demonstrating that, and high quality care and informing policy and explaining what palliative care is, I do strongly believe that we need local patient level data and evidence to achieve these goals, to try and construct something that we may think is quality. And the WHO measures, which we'll hear more about today, which are about drug availability, education and government policy. We've recently been doing some work considering what that might mean, and again we have published some arguments that this strategy cannot be achieved without evidence to underpin it. So research has to drive this model in each region. And using evidence is helping us to drive up the methodological rigour to achieve quality, so we're moving from tool development into cross-sectional implementation, audit, and now we're moving into trials. And Kira's here, who's working on her PhD on a palliative care randomised control trial in Kenya. So we're trying to drive up the rigour to achieve that quality. And really nice, I've been talking about patient-centred outcome measures. Really importantly, there's a recent paper that's come out from the field, 72 delegates at an African palliative care conference, saying that measuring quality of care has been achieved through using the tool in Africa, the African POS. So to conclude my thoughts on quality, if we're going to apply these standard definitions of what constitutes quality, I think there are some strengths that we need to look at from low and middle income countries in terms of patient-centeredness and new and original models of care. We do have additional resources in high-income countries, but I think the strengths of person-centered medicine that we've seen today need to be taken into account. And models of care should not, and probably are not, the same around the world. We all share a definition of what palliative care is, but what it looks like is very different. And the key considerations to lead what it looks like are around culture, epidemiology, finance, of course, patient needs and preferences. I don't think we need to change the definitions, but the research will reveal very, very different findings when we apply those definitions. Although I think the two common things that we can be most confident about is that we need to focus on issues of coverage and drug availability. Thank you.